Greetings from Las Vegas. I just want to apologize for not being there with all you guys. I'm sure you're having a great time. Life happens, and Gordon, you almost had me when you used that little quote, "Life is short," and that speaks to me for sure. And I agree with you. Life is short, and I wish I was there to celebrate with you guys and have some fun again, as we did a couple years ago in Scotland. With a few minutes that we have together today, I just wanted to present some of what we've been working on here in Las Vegas with a rehab protocol for chronic lateral ankle instability, something that I think is helpful for physical therapists as well as other orthopedic surgeons that are just starting out in the use of the internal brace, especially for ankle instability. And this really can give them some guiding light, and is what we use for our prospective study. So Gordon got me interested in the internal brace for lateral ankle instability probably all the way back in 2012, maybe in London. I went back to Las Vegas and started doing these procedures, and we didn't really have a defined procedure per se, and we certainly didn't have a defined rehab protocol for these patients, but Gordon showed that his patients were showing fairly good outcomes with an accelerated rehab program, meaning potentially return to sport a little sooner. The next study was published by Coetzee, and this was a retrospective study. They looked at 81 patients and similarly showed a quicker return to sport. And as we know, Coetzee is pretty aggressive in his rehab of these patients as well, although it was not really defined in their study what the rehab protocol specifically was. Myself and a few others partnered with Arthrex and developed a protocol for a randomized controlled study to be done on patients receiving either the internal brace with modified Brostrom or just the modified Brostrom alone. And we published this data in 2020 in Foot and Ankle International, and showed that the internal brace augmentation, no surprise to us, allowed for an earlier return to their pre-injury level of activity about 4.2 weeks earlier. Here this data showing graphically where we can see 13.3 weeks on average for the modified Brostrom plus suture tape augmentation to return to pre-injury level of activity. When talking about rehab, adverse events can negatively affect a study. And in our study, we had 10 of the 124 patients, or 8%, which couldn't effectively progress with our accelerated rehab program and had to be actually pulled from that part of the study. So 5 of them developed basically excessive pain from the rehab and said, I can't progress on the timeline that you require. 4 out of 5 of those 5 patients were in the modified Brostrom group alone, and this data may suggest that the internal brace really helps us accelerate their rehab and allow them to stay on that quicker timeline. We only had 2 patients in the suture tape augmentation group that failed to return to the pre-injury level of activity by 26 weeks, whereas the modified Brostrom alone group, 6 out of 48 or 12.5% did not return at 26 weeks. Our study went on to conclude that the suture tape augmented patients reached return to their pre-injury activity level 4.2 weeks sooner than the Brostrom group, and that the suture tape group had no recurrent instability cases and fewer complications overall. And these patients were actually able to better tolerate an accelerated rehab protocol. And that's really the focus of today's talk. I know everybody's familiar with this data as it's been shown time and time again, but the native ligament fails at about 150 newtons, and when we just do a brostrum with anchors, the failure is somewhere around 70 newtons, but when we add that internal brace augmentation, the failure rate goes up to 250 newtons, which is actually stronger than the native ligament, which in turn allows us to aggressively rehab these patients early. The goal for our present study and what we hope to publish is an established rehabilitation protocol for early immobilization following an internal brace augmentation that surgeons around the world really can use as their guideline for rehabbing their patients post-operatively. I'd just like to review quickly the surgical procedure as I do the modified brostrum. Here we're marking our incision, which is about a 3 to 4 centimeter incision over the lateral ankle. We'll get down to the lateral ligaments, elevating up the fat pad and revealing the extensor retinaculum and the cuff of tissue off the distal aspect of the fibula. Then we'll typically utilize the blue guide and place that into the sinus canal and use that to place my guide wire for placement of my Taylor screw. You can see that we've placed the guide wire through the blue guide in the bottom left, and then I'll typically check a fluoroscopic image mainly on the lateral to make certain that there's no violation of the subtalar joint. We'll then drill and tap and then place our fiber tape at this time. There is a small window on the swivel lock anchor that allows us to know when our anchor is flush with the lateral aspect of the talus. Once this Taylor swivel lock is in place, I'll then place my two fiber tack anchors into the distal fibula. You can also use a single double-loaded fiber tack anchor, which I've done sometimes, as it does decrease real estate needed. And then once this is completed, we go ahead and get large bites of the extensor retinaculum as shown on the left view, and then on the bottom we're placing our second anchor, which is a 3.5 millimeter swivel lock, into the distal fibula. And here's our final construct with our internal brace in place. You can see on this 3D reconstruction CT where the anchors go. Here's one in the talus in what I would say is the correct position, and one anchor in the fibula. Quickly, we'll take a look at our recommended early mobilization rehab protocol. In days 3 to 5, we emphasize phase 1, which is essentially to protect the repair and obtain edema and pain control. During this time, we'll just recommend rest, ice, and elevation, and splint immobilization. In the next phase, the patient returns to the office and we check their wound, and then we'll go ahead and place them into a cam walker boot, allow weight bearing to tolerance, work on range of motion including dorsiflexion, plantar flexion, and eversion, trying to avoid inversion stresses. And then as well, we let them get on a stationary bike, come out of the boot several times a day to work on range of motion. And for this reason, I typically use nylon suture that I'll leave in for 3 to 4 weeks total, as I know that the patient will stress their ankle during this time, and I want to try and avoid a wound dehiscence. The patient will then return to the office at the end of week 3, and if they're doing well, I try to get them out of the cam walker boot and place them into an ASO ankle brace. At this time, we progress the physical therapy with a physical therapist, working on resisted range of motion exercises and continued progress with their entire rehab protocol. At this point in time, they can also begin to work on proprioception training bilaterally. Between weeks 4 and 6, we continue the same protocol and add in as the patient tolerates. Sometimes we can even get these patients on a treadmill and get them to walk at a fairly rapid pace, and I've had patients at the 4-week mark actually be able to jog in a straight line up and down the hallway. So you can certainly begin to add in other exercises and weight training at this juncture as well. By week 6 to 8, my goal is to have the athlete or the patient in a regular tennis shoe and continue to use their ASO ankle brace during this time. I recommend advancing their activity, and most of my athletic patients are now running and starting to do sport-specific training. At weeks 8 to 12, we really can see most of these athletes returning to their pre-injury level of activity, and that's our goal here with agility training and sport-specific training continuing. There's nothing that I won't let patients do at this point if they're showing nice progress with their rehab protocol. So this is the protocol that we use to get our patients back to action a bit quicker, returning them to the pre-injury level of activity around 13.2 weeks from the time of surgery. I do believe that this program works very well, and our study took all comers and included even some workman's compensation patients that likely skewed those results. In my own experience, if we only took a subset of athletes, I think that number would be much lower, probably somewhere in the 9, 10, 11 week range, as I've seen some of our athletes back out playing their sport that involves cutting as early as 7 or 8 weeks following surgery. So this is a couple case examples of showing how that accelerated rehab protocol gets our patients really back to play a bit quicker. This is one of our local collegiate athletes, soccer player. She's only about 5-6 weeks out from her surgery that included talar dome, OCD lesion debridement, curettage. She looks really good here. And then in the second video, she's demonstrating box jumps. That's closer to the 3-month out mark in that video. But overall, she looks exceedingly good in these videos. You can see she's beginning to jog and run. And now at this point, we'll pick up her in-town rehab protocol with our local physical therapist. This individual was a Division I collegiate diver, now in Las Vegas. If any of you are familiar with our Cirque du Soleil shows that are in various hotels, and really it's a worldwide tour, but this guy's a diving performer. He's showing you that he had left ankle surgery. Believe it or not, he's only about 5 weeks out from the time of surgery in this video, but it just speaks to the accelerated rehab protocol, which this guy got through the trainers at Cirque, and he really demonstrates how quickly we can return these athletes to normal. So tell us about yourself right now.
Hi, I'm Jen. I'm on UNLV cheer. I'm about 7 weeks out from ankle surgery, and I'm back to running, tumbling, and stunting at cheer.
So the ankle's feeling pretty good for you right now?
Yeah.
Solid? You don't feel any instability at this juncture? Nope. And you're able to, how soon after your surgery were you able to start doing some of those things?
Pretty fast, like 3 or 4 weeks.
Okay, great. So what I want you to do now for us is, in a second, go. Okay, go ahead. Excellent. That feels pretty good. Okay, point to the ankle that we operated on, so the right ankle. Okay, go ahead and jump up and down. Good, excellent. And face the wall. And let's see you jump up and down. Really good. All right, looks good. So in conclusion, this is the first rehab protocol that I am aware of created specifically for post-operative patients that have undergone an internal brace augmentation of their brostrum. We had 98.2% of our patients able to complete the accelerated rehab protocol and have a full recovery with improved ankle instability and no complications of instability, wound healing issues, or the need for revision surgery. We conclude that our early rehabilitation program allows for early and safe return to activity with a low complication rate. So thank you everybody for your attention. Just thought I'd leave you with some fond memories I have of a couple years ago in St. Andrews with the whole crew, and boy, we had fun. That was a great week and one that I will always remember and treasure for sure, as I know my wife Judy as well. So thank you, and sadly I won't be there to be the event photographer this year, but in future years hopefully we can do some more of these worldwide tours, because they are so fun. All right guys, enjoy the rest of your trip and meeting, and Godspeed.